Good morning again. So I will have two lectures today. The first one I will start with the practical highlights in cancer care management. I think many of you in this room treat cancer pain patients, right? The outline today include cancer pain, cancer care management, and we will focus on the WHO analgesic ladder. Cancer pain is pain caused by cancer or its treatment, including surgery, chemotherapy, and radiotherapy. Pain is common or very common in cancer patients, so it's unavoidable to treat cancer pain. The pathophysiology includes many mechanisms leading to nociceptive pain, neuropathic pain, and a combination of both pains. We have to know at least that pain has two components. The first one is ongoing pain, and the second one is breakthrough pain. This is the basic to plan the treatment. For the assessment, we have to assess the patient and we have to assess the pain and reassess the pain. The second point is we have to assess the patient and reassess the patient. We cannot access only the pain but not the patient because we have to see the patient for the holistic approach. And the other thing, we have to assess and reassess our ability to inform and communicate with the patient and the family. WHO emphasizes on the communication ability of the healthcare providers as well in treating cancer patients. These are the measurement tools that usually used to assess pain intensity in pain patients. Normally, I do not use these measurement tools because we have to use pen and paper. I use the verbal number called rating scores by asking patients. The cancer care management, first we have to select the appropriate analgesic. When we select the appropriate analgesic, we have to prescribe the appropriate dose, not too low and not too high. And then we have to administer the analgesics by appropriate route, which patient can use the oral route, which patient can use the parenteral route. And then we schedule the appropriate dosing interval because each opioid has definite interval or duration of action. And very important, for patients who have continuous pain or persistent pain, we have to prescribe analgesic on around the clock basis, like regular basis. And we have to provide the PRN doses for breakthrough pain as well. And we should titrate the dose aggressively because cancer patients do not have long time for us to adjust the adequate treatment. This is the recommendation by the World Health Organization to give the analgesic by the mouth, by the clock. It means around the clock to maintain the plasma level at the therapeutic range and for the individual with attention to details because each cancer patient has specific diseases. This is very important for treating the cancer pain. This is the WHO analgesic ladder. It now has 3 ladders. The first ladder is for the mild pain with the pain score of 1 to 3. And the second ladder is for moderate pain with the pain score of 4 to 6. And the last one on the third ladder is for the severe pain with the pain score of 7 to 10. So when we start the treatment, we start at the appropriate ladder for the severity of pain. If a patient comes with a pain intensity of 8 out of 10, we start at the final step or the third step. We don't do the titration from the first step. WHO analgesic ladder 1 is to use non-opioids to treat mild cancer pain. and there is no significant evidence to support or refute the use of paracetamol or NSAIDs alone or in combination with opioids for mild to moderate pain. And for the adjuvant analgesics, be used in conjunction with opioids to treat many conditions of pain such as neuropathic pain. Steroids are among the most commonly used adjuvants for management of cancer pains of several types, including metastatic bone pain and visceral pain. For the antidepressants, WHO makes no recommendation for or against the use of antidepressants to treat cancer-related neuropathic pain. For any cancer patients who have neuropathic pain, we follow the standard neuropathic pain guideline, but we still follow the WHO analgesic ladder. So for those patients, we recommend to use opioid to treat cancer neuropathic pain. For the WHO analgesic ladder 2, this is for mild to moderate pain, or for cancer patients who have mild pain which doesn't respond to the non-opioid, or for those who cannot tolerate the side effect of non-opioid. The main drug for step 2 is weak opioids. In Thailand, we do have only codeine and tramadol, and you can combine weak opioid with non-opioid in step 1 because they work with different kind of mechanisms. This is based on the multimodal analgesia. For the step 2, given the lack of data on effectiveness of weak opioid on cancer pain, many people have proposed the abolition of the second step. So we can use opioid, which is the strong opioid such as morphine early. However, the recommendation for WHO analgesic ladder step 2 are for mild to moderate pain. Weak opioids can be given in combination with non-opioids in step 1. As an alternative to weak opioids, low dose of strong opioids can be an option. Although this recommendation is not clearly part of the WHO guidelines, and there is no evidence of increase of adverse effect from early use of low dose of opioids instead of the step 2. And the last one is the WHO analgesic ladder step 3. Step 3 is for moderate to severe pain, or the pain score about 7 to 10 out of 10. Step 3 is to use the strong opioids. You can use strong opioids in combination with non-opioids in step 1 because they have different mechanisms of action, but it is not recommended to use strong opioid in combination with weak opioids, such as use morphine around the clock with tramadol around the clock, because they work at the same mu receptor, and if the mu receptors are occupied by tramadol, morphine cannot have its action. Okay, although a variety of strong opioids exist, and there is no superiority of one opioid over another, morphine is the most widely available and prescribed throughout the world. The opioid of first choice for moderate to severe cancer pain is oral morphine. Morphine and in the oral form. The average relative potency ratio of oral to parenteral morphine is between 1.2 to 1.3. The dose of oral morphine is higher than the dose of parenteral morphine because of the first part hepatic metabolism and low bioavailability after oral intake. The morphine, the first one of morphine is the morphine immediate release which is available as syrup or tablet. Its onset is 20 minutes. It's the fastest onset of all forms of oral morphine, and the peak effect is at 60 minutes. So you can repeat immediate release morphine tablet or syrup at every 60 minutes or 1 hour because it reaches its peak effect at 60 minutes. Because of its fast onset and short duration of action, so it's suitable for initiation of the treatment, and it's suitable for treating the breakthrough pain as a rescue medication. However, if you would like to use morphine immediate release to maintain the treatment, you have to give it every 4 hours as a background around the clock dose because its duration of action is only 4 hours, except your patient has low uric output or renal impairment. And on the other hand, we have control of sustained or prolonged release morphine as well. The first one is morphine sustained release tablet or MST, which lasts for 12 hours. You can repeat it every 8 to 12 hours. And another one is carbonyl, which lasts for 24 hours. So you can give it to the patient once daily or every 12 hours. For the breakthrough pain, it's very important to maintain the therapeutic plasma level to prevent the persistent pain, and we have to be ready to give PRN doses at any time when pain patients have more pain, and the dose of breakthrough pain or the dose of the rescue morphine is calculated along with the dose of the around-the-clock morphine. One dose of rescue morphine equal 10 to 15% of the dose of morphine in a day. Or if you calculate per dose, it will be 50 to 100% of the regular morphine dose. You can administer PRN morphine every 60 minutes because its peak effect is at 50 minutes. And you can do more advanced treatment by giving morphine before the patient has pain, but you have to be sure that the patient will have pain. So it's called anticipatory analgesia for predictable breakthrough triggered by known events. When you increase the dose of around-the-clock dose, you have to increase the dose of PRN as well. But in my practice, in some patients who have high dose of around-the-clock morphine, they have very tiny dose of morphine PRN because physicians are very aware of the additional side effect. But in fact, if you use the around-the-clock dose at high level, the PRN dose must be high as well. If it helps in your hospital, if you have to choose to have only one morphine, either sustained release or short-term relief, if a health system must choose between one formulation or the other, immediate release morphine should be chosen as it can be used at both maintenance and rescue medication, whereas slow release morphine cannot be used for rescue. In Thailand, many small hospitals they have only the sustained release tablet, and it's very, very hard to treat the breakthrough pain. And for the parenteral administration, it's indicated when the patient has no ability to swallow, has a lot of nausea, vomiting, got GI obstruction, or limited GI absorption. This is the predictable side effects of morphine: constipation, nausea, vomiting, sedation, and dry mouth, and so on. For nausea and vomiting and sedation, patient will develop tolerance to side effects. So you can increase the dose. But constipation, patient cannot develop tolerance to constipation. It means when you start prescribing opioids such as morphine, you should start prescribing laxative along with morphine, and it's for the around-the-clock basis, not for the PIN basis. This is the prophylaxis treatment. And when you increase the dose of morphine, please increase the dose of laxative as well. These are the less common side effects. If your patient do have the side effects from opioid treatment, you can reduce the dose of opioid to reduce the incidence or severity of the side effect. But it's not that easy because you to reduce the side effect, but you to maintain the adequate pain control. So in some cases, you might have to add another analgesic as well to maintain the pain control for the patient, or you may need to have intervention like peripheral nerve block or neuraxial block. And if you cannot control the side effects, you might have to do the opioid switching or opioid rotation. It means you have to switch from one opioid to another opioid. Alternative strong opioid, pethidine. Pethidine is not popular in my hospital. Pethidine cannot be used for long term, especially in cancer patients, because the accumulation of norpethidine may lead to CNS side effects such as convulsion, tremor, or something else. So another thing is the fentanyl, because fentanyl has high lipid solubility, so it can be applied to the patient as transdermal fentanyl. However, its onset is very slow, about 6 to 18 hours, and the duration of action lasts for about 48 hours to 72 hours. So you can see that the onset is long and the duration of action is very long, so it's indicated only in patients with stable pain. You should titrate with short-acting opioid first before trying the fentanyl patch, because if you do not titrate with other short-acting opioid and you go directly by applying the fentanyl patch, if the patch, the dose is too high, it's very difficult to manage, because once you remove the patch, the plasma level will drop by 50% in 16 hours, and even the plasma level drops by 50%, it might still be in the toxic range. So be careful of that. And for the patient who have fever more than 40 degrees Celsius, the absorption is small. 1 Celsius, the absorption will be increased by 3%. Methadone is an effective analgesic. It has an NMDA antagonist effect, and it inhibits the reuptake of serotonin and noradrenaline as well. However, even methadone is very, very good. It's a little bit difficult to use because the half-life is uncertain, and the half-life can be longer and longer. That may lead to delayed respiratory depression. So if you would like to use the methadone, you have to do some more practice to get familiar to this drug. Oxycodone is another strong opioid which acts on kappa receptor. So now I would like to talk on opioid conversion table in case that you might have to do the opioid rotation or opioid switching. Conversion ratio can never be more than an approximate guide for several reasons, because there is wide inter-individual variation in opioid pharmacokinetics and many other factors that you can read from the leaflet. This is the slide from the WHO showing the conversion ratio of the opioid in comparison to morphine. This is for the oral conversion table. And this is from conversion from morphine, either oral form or parenteral form, into fentanyl patch. It's easy to remember that Every 60 milligrams of oral morphine equals fentanyl at 25 micrograms per hour. If you have to decrease or stop morphine in any patient, you have to be careful of the possible withdrawal effects. So for patients using morphine for less than 2 weeks, you can stop right away. However, if patients use morphine for more than 2 weeks, you can follow the WHO guideline for tapering the morphine dose in order to avoid the occurrence of the withdrawal symptom. Why you have to cut down or stop morphine in cancer patients? One, the patient might have intolerable side effects, and two, in some cases, the patient are really lucky from painful to pain-free state, so you don't have to use morphine anymore. About 10% of cancer patients do not respond to conventional treatment, so they might have to go for invasive interventional techniques, such as intrathecal drug delivery or epidural administration of opioids. For the end of life, in some occasions, as patients are nearly dead, pain is perceived to be intractable. In this situation, sedation may be the only therapeutic option capable of providing adequate pain relief. However, sedation should be a rare intervention of pain. In any institutes that use a lot of sedation to treat pain in the end state, the WHO recommends to do the audit. Take-home messages. A range of pain management options is available at every stage of cancer, from early to advanced. It's important that patients are fully involved in discussion and decision about their treatment, such as Mary just told us before. And the last one, the WHO analgesic ladder is established as effective guideline with 88% of satisfactory pain relief. So for cancer pain management, please follow the WHO analgesic ladder guideline. Thank you very much for today.